Welcome back, everyone. Today, we are diving into one of those classic medical snapshots. You know, the kind of diagnosis you can make from across the room before the patient even says a word. We are talking about Duchenne Palsy, famously known as the waiter's tip position. Dr. Sarah, are you ready to get into the weeds of the brachial plexus?
I'm always ready for the plexus, Dr. Khan. While it can be a nightmare for students to memorize, Duchenne is actually quite logical once you map out the anatomy. High yield for the boards, we are talking specifically about an injury to the upper trunk of the brachial plexus, involving the C5 and C6 nerve roots.
C5 and C6, the top of the tree. Now, imagine a person falling off a motorcycle and landing hard on their shoulder while their head is pushed violently in the opposite direction. Or, in a delivery room, a difficult birth where there's traction on the infant's head. That stretching, that tug of war between the head and the shoulder is the classic mechanism. It literally tears those upper fibers.
Exactly. And because C5 and C6 feed into several major nerves, the clinical presentation is a perfect storm of muscle failures. To be precise for those taking exams soon, the nerves most affected are the suprascapular nerve, the axillary nerve, and the musculocutaneous nerve. When those go dark, the arm loses its power players.
It's like the power went out in half the house. Let's walk down the limb. Why does this matter clinically? Well, look at the shoulder first. It's adducted and medially rotated. Why? Because the abductors, the deltoid and supraspinatus, are paralyzed. It's like a crane with a broken cable. The arm just hangs there by the side.
And don't forget the rotation. Because the infraspinatus and teres minor are out, the lateral rotators are gone. This allows the pectoralis major, which is still getting some innervation from lower roots, to pull the arm into medial rotation unopposed. It's that inward twist that really defines the look.
Right, it's that inward spiral. Now move down to the elbow. It's straight, extended. Why? Because the musculocutaneous nerve is toast, meaning the biceps brachii and the brachialis, our main flex your muscles, can't do their job. Gravity and the triceps win the battle, keeping the arm straight.
And finally, the forearm is pronated. This is a big board favorite. The biceps is not just a flexor, it's our most powerful supinator. Without it, the pronator muscles, which are mostly innervated by the median nerve from lower roots, take over and flip the palm backward. So, adducted, medially rotated, elbow extended, forearm pronated. There's your waiter's tip.
It's the classic, hey, give me a tip posture behind the back. But Sarah, beyond the look, we have to think about sensation. If I'm a patient's doctor of choice, I'm not just looking at the motor function, I'm testing the skin. Where is the sensory loss in a C5, C6 injury?
That's a vital point. You'll see sensory deficits along the lateral aspect of the arm and forearm, specifically the lower half of the deltoid, supplied by the axillary nerve, and the lateral forearm, which is the territory of the lateral cutaneous nerve of the forearm, the terminal branch of the musculocutaneous. If they can't feel a pinprick there, it confirms those upper roots are involved.
Why does this matter clinically? Because we have to distinguish this from other injuries. If the hand itself is totally fine, if they can still make a fist and move their fingers, you know the lower trunk, C8 and T1, is intact. This is strictly an upper floor problem. If you see a claw hand instead of a waiter's tip, you're looking at clump case palsy, which is the exact opposite end of the plexus.
Spot on. Board exams love to contrast ERBs and clump Ks. Just remember, ERB is high, C5, C6, and looks like a waiter. Clump K is low, C8, T1, and looks like a claw. Also, keep an eye out for the Moro reflex in newborns. An infant with Duchenne won't be able to abduct that affected arm when startled.
It's heartbreaking to see in a neonate, but the good news is that many birth-related cases improve with physical therapy. In adults, though, with high-velocity trauma like that motorcycle crash, the prognosis can be a bit more wait and see, depending on whether the nerve was just stretched or actually avulsed from the spinal cord.
Precisely. And for the students listening, if the question mentions the nerve to subclavius or the long thoracic nerve, pay attention. The long thoracic nerve comes off the roots directly, C5, C6, C7. If the patient also has a winged scapula, that tells you the injury is extremely proximal, right at the root level, rather than further down the trunk.
Great catch. It's all about the levels. If we sum this up for the folks on the go, Duchenne is a C5, C6 upper trunk injury, usually from a wide separation of the neck and shoulder. You get paralysis of the deltoid, biceps, and rotator cuff muscles. The clinical result? An arm that is adducted, medially rotated, and pronated, the classic waiter step.
And don't forget the sensory loss on the lateral arm. Master those 4 muscle actions and the roots, and you've got this topic locked down for the boards in the clinic.
Perfect. Short, sweet, and high yield. Thanks for joining me, Dr. Sarah. We'll see you all in the next episode when we tackle the lower half of that plexus.